Thank you very much for the privilege to present our work at this meeting here. We have no relevant disclosures. Donation after circulatory death is well established in lung transplantation in most countries and contributes around 10% of lungs transplanted worldwide. Outcomes have been shown to be equal to donors after brain death. Recently, DCD organs are being increasingly utilized for heart transplantation as well, using two main protocols: direct procurement, proposed by the Sydney Group, and normothermic regional perfusion, developed by the Papworth Group. This talk will only focus on direct procurement approach. In DCD lung procurement, following a switch-off and an agonal phase, circulatory arrest marks the start of warm ischemic time, and after a hands-off or standoff time, skin incision is performed and ventilation is reestablished as soon as possible. Then, after cannulation of the pulmonary artery, lung perfusion is started. When the heart is also procured, the following sequence has been established at our institution due to the heart's known very limited tolerance to warm ischemia. Heart perfusion and procurement is prioritized. So it is first to provide optimal conditions for the cardiac team, while the lung team only stands by at this point. Lung ventilation and perfusion is only started after the heart has been explanted. Now this approach, of course, minimizes the heart's warm ischemia, but what about the lungs? We asked ourselves, does this prioritized heart procurement approach in DCD donors affect the outcomes for the lung grafts? We performed a retrospective analysis between 2012 and 2022, reviewing our early experience with this type of procurement. We excluded recipients with retransplantation, lobar transplants, pediatric patients, and multi-organ transplants. Looking at exclusions of donors, we initially accepted 68 DCD lungs. 4 of them did not progress to circulatory arrest. 7 were later rejected at the table, and there was 1 abdominal regional perfusion, which we excluded since it was a direct procurement approach. We compared 49 patients where only the lung had been procured and 7 after prioritized heart procurement. Donor parameters such as age, smoking history, O2 score, and the PF ratio were similar in both groups. The median time between circulatory arrest and lung perfusion was 13 minutes in the lung-only group. In the heart and lung group, this period was significantly extended to 24 minutes. To correct for different hands-off times in different jurisdictions and centers across Europe where we performed these procurements, we also compared the median time between skin incision and lung perfusion. This period was just 5 minutes in the lung-only group, but almost tripled to 14 minutes in median in the heart and lung group. Recipient demographics and operative parameters, including age, LAS, ECLS bridging, and intraoperative ECMO use, were comparable in both groups. Intraoperative red blood cell and plasma unit use was slightly higher in the lung-only group. Moving on to outcomes, looking at primary graft dysfunction after lung transplantation, this was comparable in both groups. While the rate of PGD grade 3 in the lung-only group was only 2.2% at 48 and 72 hours respectively, none of the patients in the heart and lung group developed any higher grade PGD. Clinical outcomes after lung transplantation were comparable as well regarding length of mechanical ventilation, ICU stay, length of hospital stay, and in-hospital mortality. Early graft survival at 1 year was excellent in both groups and comparable with 90.3% for the lung-only group and 100% for the heart and lung group. In conclusion, prioritized heart procurement in DCD donors leads to delayed ventilation and perfusion of the lung, and thus a longer warm ischemic time for the lung allografts. However, these lungs show similar early outcomes after lung transplantation, and therefore we are confident that this practice does not jeopardize lung outcomes. Thank you very much, and I'm looking forward to your questions.
This paper will be discussed by Dr. Ashish Shah from Vanderbilt University.
Well, thank you for the opportunity to review your manuscript and your paper and the opportunity by the Society. So the authors have reviewed a relevant, albeit small, experience in the world of DCD donation that addresses the question whether heart recovery and delays in lung ventilation, presumably prolonged warm ischemia and potential injury to the lung, is associated with worse lung outcomes. The authors conclude that a short delay is not associated with worse post-transplant outcome. It is important to note, as you have noted in your talk, this is really about direct procurement and not about normothermic regional perfusion, exactly, which will be a completely different fish, I believe. In your manuscript, you actually mentioned that heparin is given when allowed. Have any of these cases involved donors that did not get heparin prior to withdrawal? And the second, well, you can answer that, go ahead.
So since we procure lungs across the Eurotransplant region, this is different according to centers and jurisdictions. So at some centers it is allowed to give medication such as heparin before withdrawal, and this was the case in some of these cases. In donors where this was not allowed, we put 10,000 units of heparin in the first bag of Perfidex perfusion and performed explantation this way.
Did you recover hearts when you were not allowed to give heparin?
It's likely that this was only cases where the heart was procured. That's correct.
Okay. My second question is, the actual warm ischemic times are really quite short in both groups. So what, in your team's mind, what would be the limits to where you wouldn't utilize the lung? How long would you wait for that heart team to get their act together?
So what gave us the confidence to step aside and leave the thoracic cavity to the cardiac colleagues was our confidence in the ability of the lung to accept prolonged periods of warm ischemia. We would wait for up to 2 hours for circulatory rest to set in, so we're well within those limits. Of course, ventilation is also a factor, and we know that the lung is more tolerant to cessation of perfusion as long as ventilation is reinstituted early. I think for these reasons, it's not really up to us, or we won't come into the range where we will have fears probably because the heart warm ischemic time will be the limit in this question.
Good. So I'll just conclude with just a comment. I think we're at the very beginning of really understanding the limits of warm ischemia and novel strategies to rescue these organs. DCD for heart transplant is here to stay, and the challenges associated with multi-organ recovery will grow unless we truly understand what actually matters and what doesn't matter during these recoveries. So I applaud the author's initial look at this issue and look forward to future work by your very esteemed group to see what the true physiologic limits are, and for other groups to really understand, you know, ultimately where NRP fits in this, because I have the sneaking suspicion this will be very different. And so we look forward to future presentations. A very nice presentation.
Thank you.
Gerrit?
Ramnon Leuven, Belgium. A very nice presentation, and congratulations with the excellent results. I have a question regarding your heart and lung group with regards to the numbers. So were these hearts and lungs transplanted all in Vienna, or were there cases that the heart was taken by another group and only the lungs were transplanted in Vienna, and vice versa. When lungs were taken by another group, these were not included in this series.
So this study was purely from the outlook of a single center lung transplant center. Some of these hearts were procured by the Vienna heart transplant team, some of those by other teams.
Okay. But the results on the outcome of the lungs is only on the lungs that were transplanted in Vienna.
Yes, exactly.
I'll ask one question if I may. So I apologize if I missed it, but so you transplanted 7 sets of lungs from situations where the heart was procured with DPP, correct?
Yes.
Were there any situations where you went out with the intent to procure lungs when a heart was being procured and ended up declining those lungs?
There were instances where there was pneumonia, for example, but there was no exclusions based on the prioritized heart procurement.
Okay, so what criteria did you use when you went out to look at the lungs after you were there in the chest? Basically, I'm asking, under these situations, what would make you decline a set of lungs where the heart was being procured? Do you look at compliance, the bronch, other sorts of strategies like that? Or
Exactly.
did you have a defining time period for warm ischemia as well?
Since we are confident that the lung will tolerate the warm ischemia, there was no fixed limit, but we looked, as you said, at bronchoscopy, at elastic recoil, and of course at the parenchyma quality at the back table, but we always explanted the lungs and judged them on the back table before accepting or declining.
Great. Anyone else? A very nice presentation. Yeah, I think as Dr. Shaw alluded to, I mean, this is a very dynamic and changing field, and I think this adds significantly to the literature, but one of the real questions is what's going to be the impact of NRP. Does anyone in the audience have experience with transplanting lungs from a donor where NRP was used to procure the heart?
I do too, but go ahead.
Sorry. Van Gleuven. Yes, we did 2 cases in our center, and we had a medical student who did a world survey, and she collected 5 cases, and I think your case is included in that as well.
So, Dirk, to be clear, I'm sorry, you've transplanted how many?
2.
2?
2 out of 8 NRP thoracoabdominal NRP procedures. We declined 2 other lungs because of bad quality.
Because of back table assessments. And you transplanted both of those directly or with EVLP?
Directly.
Directly?
Yeah.
Yep. Ashish?
I'll say, I think there's probably 5 or 6 NRP cases we've gone out for. 2 we utilize for lung transplant. The other 4, I'd say, Matt Paquette, who runs our program, elected to send those to lung bioengineering to pump. They all failed. Mm-hmm. The last 2, so I'm going to add another 2. As soon as we reperfused on NRP, those lungs really failed badly. And I think we are in the midst of trying to understand if this is just, a couple cases. Again, these are small cases, so it's really hard to know. But I suspect there may be another injury that's possible with reperfusion. It could be neurogenic also. Even though we do interrupt the cerebral circulation, there may be some other element here we're missing. So, as you said, we're going to see how this shakes out in the future.
Yeah, I think real quickly, our experience in Cleveland has been, I think we've done 3. One set of lungs for NRP we transplanted directly. Actually, Dr. Ahmad transplanted those. I think Vanderbilt took the heart. And the other 2, we put both those on EVLP because we had concerns, and both of those sets of lungs ended up not being transplantable.
Yeah, and I think one of the things that Matt is a little worried about is that maybe even that second EVLP run might, there's some priming that may be going on. I mean, I don't want the audience to think that we have a total grasp of this. These are very, unique, potentially unique cases, but there's definitely a signal there that we need to look into this a little bit closer.
Yes, yeah, I completely agree. Okay, thank you very much.